Good evening, everyone. Thank you for joining the Grand Rounds tonight. To get started, let us first share the routine slides that will take you through your CME and MOC credits. Again, this Grand Rounds will be hosted on the website, so you'll be able to log in and view it there. Please convey this information to your colleagues if they have missed the Grand Rounds. And you'll be able to take the CME credit for this session. Please text 25676 to number 888-816-4893. Once you have an active profile in Rutgers Cloud CME, you'll be able to log in and get credits. And I'm very excited that the credits are being well received all across the health system. People from different hospitals are joining in. Make sure, please, that you have your active profile in Rutgers Cloud CME if you want to avail the CME credit. And if you want to get direct MOC credits, please complete this first step. And using the room code Future 2025, you'll have this link, which will be displayed again in the web chat. Plus, also, there's a barcode that is coming in. You may be able to scan the barcode. And if you answer scan the barcode, and if you answer the questions correctly, then your MOC credits directly go into your ABIM ID, provided they have been provided again with your Cloud CME profile. With that, I'm really excited today to bring in one of our own colleagues, Dr. Omar Khalik, who is, I would call, he's our neighbor, and he's now very well known to some of our faculty members, Dr. Bakari and also Dr. Drew Mendoza have a good connection with him. Dr. Bakari knows him from his stay at Columbia, and also Drew Mendoza trained with Omar. And I got to know Omar almost very recently in the last 1 or 2 years, and a couple of times when we shared the podium during recent conferences. I would say one thing which strikes when I was going through Omar's CV is that he has almost satisfied single-handedly every single society. So you have your FACC, you have your SCMR, SSCT, ACC, ASC. So you're one of those ambassadors for all of these societies that can say that you've been comprehensively been trained, and that really comes off very well through your CV. So Omar went for his medical school at Jefferson Medical College, then subsequently Westchester Medical Center. He had his residency and fellowship, cardiology fellowship. Subsequently, he had the privilege of doing really a very extensive cardiac imaging training, first with advanced echocardiography and cardiac CT fellowship at NYP Columbia University. And subsequently, he had 2 years of an extramural cardiac MRI fellowship at Weill Cornell. Following this, he joined the faculty at Columbia, and he initially was the director of the cardiovascular imaging research, education, director of the cardiovascular, director of the interventional echocardiography fellowship, director of the multimodality cardiac imaging, and he really rose very quickly there, and subsequently was offered a position which he is currently building up at St. Francis Hospital and Health Center in Rosslyn, where he's the director of the division of the cardiovascular imaging, director of the imaging fellowships, and also the director of the cardiac imaging research and education for the DMATIS Cardiovascular Institute. He continues to be a director of the Structural Cardiac CT Core Lab at the Cardiovascular Research Foundation. He has extensive teaching accolades and awards during his mentorship and training, and he has trained some of the latest group of advanced imaging fellows who are really going everywhere, and we are really lucky to have Andrew Mendoza, who came and joined us after his training with him. He has over 130 peer-reviewed publication. He's very well represented. He's very well known in the cardiac imaging and the international as an international faculty and he has really done extensive recently has been given a lot of accolades for his extensive training in cardiac imaging, and I really learned about his CT imaging program. He's really developed a very masterful program at St. Francis Hospital. I think you have 6 imaging fellowships, and they are churning imaging work horsepower there, and it's really great for Omar to join us today at a very short notice, and really thankful for that. And you're going to tell us about the future for the structural program, and I'm really excited to hear your talk. Omar, the floor is yours.
All right, thank you very much for the introduction. Good to see some familiar names. Let me just pull this up. All right, can you see it?
Yes.
All right, so we're going to talk about multimodality imaging and interventional cardiology. It's probably some things that you're expecting and others that you may not be expecting. Here are some disclosures. The biggest one is at the bottom. I'm a multimodality imager and imaging fellowship director with a lot of passion for this topic, so bear with me. So when I trained, nobody knew what a multimodality imager was, and some people thought it was very dumb. But nowadays, everybody needs one. They want you to review all the modalities on every patient as a second opinion, third opinion, and this is what we do day to day. So what is multimodality imaging? This is an important background for this talk and the field in general. So I think imaging is one of the areas that really connects all of the different subspecialties within cardiology and is almost unique in that sense. And now we're even getting into direct referrals from internists, from hematologists, and from others, depending on what we're looking for. It should be a patient-centered approach rather than modality-centered. So traditionally, there have been silos and other problems, which I'll go through. But this is what we're really trying to achieve at its core as imaging physicians. Here are the modalities. So we have your echo, your nuclear, your CT, your MRI. My division is now consists of 18 full-time imaging cardiologists. We don't have any other duties other than imaging. It's one of the largest groups. Everyone has extra training, certifications. Everyone at this point is multimodality. We do 40 to 50,000 imaging studies per year. We're a dedicated division under the umbrella of cardiology. The complexity of imaging has increased exponentially over time. You see from M mode in the 50s, then SPECT, CT, PET, MRI, all with familiar names. And then an additional boost occurred with the structural heart revolution, beginning with the partner trial starting in 2007. And then in 2011 was the first approval of a structural technology, which was TAVR, the Edwards Sapien. This parallels the increase in research. You see here that 2005 was the first time that greater than 10 studies were published on multimodality imaging. And then you see after TAVR approval, there was an exponential increase. And now we're over 1,000 publications per year under this search heading. The birth of the interventional imaging physician was from some of my mentors. This is the legendary story that Marty Leon gave Becky a new title and coined this term, interventional echocardiography, and she became his eyes, and that was the beginning of this field. What is an advanced imaging cardiologist? Well, there are going to be different definitions coming out with the advanced training statement to be published soon. But in general, level 3 or equivalent in at least one modality, and then an advanced imaging cardiologist, multimodality, also will have proficiency or at least level 2 in other modalities as well. And there are more and more of these being produced. So there are many challenges in the field currently. Silos are very common in hospitals. Single modality imaging specialists need to broaden and become familiar with other modalities. And currently, a lot of hospitals suffer from separate managerial structures. Sorry, one second. Separate managerial structures for different divisions, and some of the modalities may be within radiology or nuclear medicine, which encourages competition rather than collaboration. Training is a big issue, so we like to call ourselves advanced imaging cardiologists. Non-invasive is a bad word, I think. Advanced cardiac imaging physician is the preferred term because that's really what we're doing. We're doing things beyond the regular training and general cardiology fellowship. This was a paper from 2006 showing where it was quoted that most readers of imaging tests in major teaching hospitals rarely are assigned to read both echo and nuclear cardiology studies. And they said certainly level 2 training in all of the modalities can be achieved in the time frame of a 3-year fellowship. And they had some rudimentary COCATS numbers below. Of course, we know this to not be true now based on the exponential increases in knowledge that we've seen. Now we're adding more and more, which is becoming a challenge. So this is a document on interventional echo, where they say you need 150 cases just for this field, in addition to all of the other COCATs. Advanced echocardiography has been one of the biggest explosions with intraprocedural imaging for structural. But really getting all of this training, including intraprocedural, is very, very tough in general fellowship. And I think it's very difficult to achieve in general. My hot take is that mastery meaning every element of a single imaging modality, cannot be completed during the general cardiology fellowship as it currently stands. Because when you're talking about a single modality, for example, echo, this is a case I'll go through later, but in this case, we used TE, TTE, IVUS, and ICE within the same case. So just within echocardiography or ultrasound, there were 4 different modalities within that one modality. So here we have our different guidelines. So if you add all of these up, level 3 and 4 modality disciplines would be 33 months and 2,100 studies, which is impossible. It's 3 extra years after your fellowship. So we need much better pathways. Here was my journey, which was hodgepodge of things. So after my 6 years of training, I did my advanced echo and CT. Then I went actually for my interventional echo fellowship and clinical valve training. And in the interim, I was going back and forth from Cornell to get CMR training as well, which wasn't available at Columbia. For board certifications, I held 6, was my maximum. I let a couple of them go, right? So here's my 4 that I kept. So this is what we're having to decide on, right? These requirements are very onerous, and we're recerting. So I have to recert my 4 boards every 6-year cycle. So it's like another 4 years of fellowship. And it becomes like this picture of Prometheus dealing with a daily pain. So there are these multiple modalities, which also cost a lot of money. So it's over $6,000 on every cycle. And there are other challenges associated with this. So with this 1 to 2 years of extra training, there's a lack of fellowships, which is now changing, but there's still a severe supply-demand mismatch because it's not ACGME. There's a lack of funding, which creates challenges in creating enough spots. And the salary surveys don't consider advanced imagers to be separate from general cardiologists, despite the significant extra training and extra certifications. There are discrepancies in how we even calculate the number of spots. So here are 2 different databases, ACC, and then another paper from JACC Imaging where the number of programs was significantly discrepant. And because of the non-ACGME format, there could be significant variations in what is taught in every fellowship. This was a structural art imaging survey from a couple years ago, showing that 49% of interventional imaging physicians learned on the job, and only 17% had a dedicated echo fellowship. And this is one of the challenges we face when probably the most difficult type of imager to hire is the interventional echocardiographer. So challenges for trainees, exposures to advanced imaging outside of the cardiology purview in your general fellowship. CT and MRI are mostly radiology-run programs in the majority of hospitals. And general radiology training qualifies radiologists to read studies as per their general board, but that's not true for us as cardiologists, so there's a mismatch there. For employment, this creates a lot of burnout, inadequate reimbursement, and that now is going into the structural field with no reimbursement for intraprocedural ICE and minimal increases for intraprocedural TE. Reimbursement for our tests, where we read a CT and get a couple $100, but for a diagnostic cath, several $1,000. There's a severe mismatch there as well, which devalues the field in a way. And this is an example of the intraprocedural imaging where the interventional cardiologist gets multiple folds higher than the interventional echocardiographer for the same time in the procedure. and the echocardiographer cannot bill for the increasing modality of ice. So this vicious cycle occurs and is creating all of these challenges that I've described. So currently there's a crisis in the lack of trained cardiologists for advanced positions and particularly interventional imaging. Here's an example of the number of programs. So imaging, 7 to 8 years of total training, board certifications, often at least 4, number of trainees, 123, as compared to EP and interventional, which have many more trainees. So are we shooting ourselves in the foot with all of these boards that have been created? This was something from 2014 recommending these board certifications. However, we're dealing with the consequences today. There are papers which are recommending increases in these requirements, which I showed you are already very onerous. So how can it be both? Because I've said there's too much training and we also need more training. Well, we need to have better pathways to enhance training and reduce our time to get to that goal. And things that are being proposed are using your 3rd year of general fellowship to gain level 3 in multiple modalities, and then to have an optional 4th year if you really want to make up the difference with all of the 4+ modalities considered within the field. Board examinations are not sustainable. A lot of people are working on this, so hopefully this is going to change. And that includes streamlining boards into one exam, perhaps eliminating recertifications and going with easier methods. So now I'm going to stop complaining and discuss some actual imaging stuff, which I think is a great field, and happy to be here to share all of it with you. So valvular heart disease is where we're going to start on the interventional side. In the diagnostic aspect, before we get into the procedures, really we're moving away from this arbitrary severe classification and moving towards significant. So what does significant means? That means prognostic cutoffs and thresholds that will help inform our decision making rather than somewhat arbitrary numbers. And MRI has evolved to a key modality with some data behind it now to define what is, quote, significant disease. Our main tools there are volumetric imaging and phase contrast. So what do we get from volumetric imaging? We get end diastolic volume and systolic volume by directly measuring the Simpson's rules in a stack. And then we'll get our total stroke volume, which includes forwards and backwards. Phase contrast imaging is similar to a Doppler. It's at one location, and it can give us the flow going forwards and backwards at that location. So when we combine these methods and also add 4D flow, we can get various types of calculations and have internal consistency to get an overall assessment. 4D flow is a newer method, but is not research. It's a commercial method, and there are sequences available for the major vendors now. And here we can get direct regurgitant measurements. The advantage of this is we get these eccentric jets. So here you see one for AI. But we can align our multiple planes now because it's a 3D volumetric data set. Here's an example for MR, an eccentric jet, where we can align our multiplanar reconstruction to make sure that we're calculating an en face flow. And here's another example with tracking. So we're actually tracking the jet through the cardiac cycle, and that helps us to gain more accuracy on the regurgitant volume. Here are some data from CMR. So we know that for aortic regurgitation, the CMR data, which are now 5 or 6 papers, show consistently this regurgitant fraction cutoff of 32% by CMR rather than the 50% by echo, which is associated with prognosis for aortic regurgitation. Here's another example of a TR flow where we're using the flow to get a direct TR volume of 75 ml. And the advantage is this is a little bit of an eccentric jet. There's concomitant MR, so it gives us a direct way to measure the flow. There have been data on CMR risk stratification as well. So you see here, this was a paper from Houston Methodist Group showing that the high-risk group in terms of prognosis had a regurgitant volume of 45 and a regurgitant fraction of 50 or above. And then we have our low and intermediate risk groups. RV function in the setting of TR has become a big topic. So I want to present these two examples of traditional RV ejection fraction, which would be end diastolic volume minus end systolic volume. So in patient A and B, we get a total EF of 50%. However, our forward stroke volume in A is 50 ml, and our forward stroke volume in B is only 25 ml because the other 25 is going backwards with the yellow jet of TR. So now we come into a concept of effective RVEF, whereas on the left, it's the stroke. In both cases, it'll be the stroke volume, forward stroke volume over RV end diastolic volume. Or on the left, this will come out to 50% because all of the volume's going forward. And on the right, it's 25%. So these are very different patients. So here's the calculation. It's the forward flow divided by the RV end diastolic volume. And in some surgical studies and natural history studies, this has predicted outcomes, including mortality, better than RVEF by itself. This is a more specific metric. And also in the triluminate imaging study, this was shown to improve after reducing TR, where other metrics, including regular RVEF, were not. RV fibrosis is a little bit of a moving target, but I think we're getting there. We don't really understand the predictability of the RV function after eliminating TR or reducing it. And I think this is going to be a method to be used in the future to help us decide when to intervene and when we're too far gone. Strain imaging is an easier method, which can be performed actually by CT and also MRI, the most basic method being free wall strain by echo. And this is a very simple and robust method, which can also help us to predict outcomes earlier than from traditional RVEF. Moving on to some structural heart procedural planning in our various subjects. We know that for TAVR, there are various ways to look at our aortic annulus area. CT is the gold standard. We can also measure by 3D TE when we're not able to get a CT for various reasons. We can also use cardiac MRI. We don't necessarily need gadolinium as well. So here's an example of a case report we published using non-contrast CT, non-contrast 3D MRA for TAVR planning. We had this dye shortage a couple of years ago, which we were affected by. And this was one of the situations where we had to use these alternative modalities. And here's an example of using cardiac MRI actually for left atrial appendage occluder planning. And this could also be extended to patients who have iodine allergy or severe CKD. Left atrial appendage occlusion has become a big area. One of the biggest topics is how to assess the post-implant leaks. So we know now that leaks are more extensive than what we once thought. They're 30 to 50% in the literature. And we have various types: peri-device leaks, intra-device leaks, and mixed leaks. And what's also been elucidated is that these are detected more frequently with CT than TE. And we'll go into that further. We also know that after years of ignoring a lot of these, that a few papers now have shown that there is a small signal for non-disabling events, TIAs and strokes that are non-disabling in even small leaks greater than 0 millimeters. And in this large study, it was shown that this leak group from 1 to 5 is actually the most susceptible because they tend not to be placed on anticoagulation due to the data from prior studies. But many people are moving away from this 5 millimeter cutoff now. Here's an example of normal imaging after LA appendage closure. We see that the device is fully thrombosed inside, which is normal. There's no contrast distally in the appendage. There's no device-related thrombus on top. So if all leaks matter, we now need to move beyond the size of the leak and what is the significance of different types of leaks. So you could have peri-device, intra-device, around the skirt. And these are going to become more, we're going to get more focus on these various findings in the upcoming years. And also with the move from TE into ICE now, CT is going to become much more important for this field. The SKY guidelines recommend that when onboarding ICE that you use T and ICE until comfortable before moving to ICE. But there is the potential for more leaks here due to the inferior imaging provided by ICE. What is driving this movement towards ICE? Well, the imaging is not as robust, but it's driven by a lot by resource factors, lack of available anesthesiologists and imagers, and desires for the implanters to get patient throughput and take charge of their procedures. But just keep in mind that ICE provides only a fraction of the views and information compared to TE. Electrosurgery is another area. One of my colleagues, Jafar Khan, was one of the founders of this field. So what is it? This is the use of electrified commercial wires in an off-label approach to modify anatomies to facilitate structural heart procedures. Here's a case of sesame, which is a myotomy, so splitting a V into the interventricular septum for various procedures. Here's an example from an animal where you see at the red arrow, this myotomy with some enhancement afterwards, so a thin layer of fibrosis. And here's another example of an intraprocedural CT from an animal where you see the wire going through the septum and exiting into the ventricle. Here's an example of a case, an 81-year-old female, status post-AVR, who has severe symptomatic MS, evaluated for a mitral valve in MAC procedure. And after the evaluation, which I'll show, the course of action was to do septal reduction for preservation of LVOT area in the setting of the need for TMVR implantation. So here's our patient after traditional alcohol septal ablation. So our neo-LVOT area increased from 42 in the initial assessment now up to 147, which you see in the middle panel. Typically, we want at least 150 to 180 millimeters squared of predicted neo-LVOT area. So we thought this was an inadequate reduction. Here's our sesame procedure. And this was the slide I showed where you see at the red dashed line on the lower right, we need to see our wire coming through from the retrograde approach from the aorta, going through the septum and exiting into the ventricle. And because of the MAC here and the various structures, bioprosthetic aortic valve, we had to use these multiple echo modalities to really be confident of the entry and exit points. So the wire is then snared, electrified, and pulled back. So now you see at the red arrow, this myotomy, which was partially successful. We didn't traverse the full length of where we wanted to go, but we did produce a split here. So we increased our neo-LVOT area from the 140s now to 180. So borderline okay. But as Jaffer says, nobody ever died from having too much LVOT area. So we proceeded for the TMVR, but with a concomitant lampoon. So lampoon means we're transecting the anterior mitral leaflet, splitting it to provide more space in the LVOT. Here's the wire coming in at 12 o'clock and down at 6 o'clock, traversing the leaflet. And here's the post result after the implantation, showing the results. And we see a tiny PVL here at 3 o'clock, but otherwise a perfect result. Newer technologies in this space: computer simulation, photon counting CT, and holography. Here's computer simulation of CT. So this is a step beyond what we do on programs like Circle or 3Mencio or Terra Recon, where we put in kind of a crude device and predict, which is more of what I showed before. This is FEOPS, so they're using finite element analysis to predict what's going to happen to the tissue after valve implantation. So this is a valve in MAC case, similar to what I showed before. Here's another competitor, DASI simulation, which does something similar with different colors. But again, the same idea, trying to predict what's going to happen to the tissue with this implantation. Computational modeling has now been studied in one randomized control trial of FEOPS, left atrial appendage, and this was done for amulet procedures. And what was shown that with computational modeling in one arm, actually there were 15% fewer closure devices used, 50% fewer device repositionings, less use of radiation and contrast, more complete closure, and better position of our left atrial appendage device, and a lower risk of device-related thrombus. So it seemed to help in multiple areas. Photon counting CT is a brand new technology, which Drew experienced last year as one of the first fellows to use it. So here's an example of a 30 cc TAVR CTA, which is fairly common for us, a patient with CKD. So these are exactly the same CT. What you can see left is the original image. It's a bit dim. And then using the photon counting spectral features, we can change what's called the KEV. This is the voltage to get closer to the physical separation with iodine to actually brighten the iodine contrast in the image. And this is different than windowing because you see on the right, all the other structures outside are the same brightness, but only the iodine is enhanced. So this is an organic enhancement of the iodine using this technology. And here's the full cine. So what you'll see here is that this is the reconstructed with the lower KV, 30 cc TAVR CTA. So we lose nothing in terms of the opacification while using a very small amount of contrast. And this is simply leveraging the technology from photon counting. Here's another example on the left of the temporal resolution using the dual source photon counting CT, which is smoother. And you see a very smooth contrast, bolus in appearance, as opposed to the more grainy appearance on the right from a traditional scanner, which is also good, but definitely a step up for the newer technology. Similarly to what I'm going to show in a bit with coronary stents, with the assessments for halt after TAVR, there's fewer artifacts with photon counting, so we can nicely see the location of the halt, the leaflet thrombosis, which occurs close to the stent frame and which could be hidden by extra blooming artifacts. This is an ultra high resolution image at 0.2 millimeters thickness. TAV and TAV evaluation, also very important to see the specific struts and nodes for the valve. So here you can see an example showing each node separately. You can see at the green, we can see the nodes with the skirt, which is the dark material in between, and also up top, the nodes without the skirt. This helps us to very precisely delineate our chances for sinus sequestration or coronary obstruction with a higher spatial resolution than we are traditionally used to. There are other aspects of this. Here's one of our abstracts now submitted for publication using contrast imaging for non-contrast calcium scoring. And this is all done by iodine removal with this technology. Holography is one thing I mentioned. This is at its early stages. So this is using a headset or other technology to move around an image in space. Here's an example of using this from the holographic display used by the operator headset, where they can actually cut down and manipulate the echo image, which is fed in, and also make measurements directly in the air. Coronary artery disease. So this is the area where we're moving forward, which is not the usual thing people think of for interventional imaging. So I mentioned photon counting CT, and I think coronary imaging is where it has the greatest utility and leap from traditional. And this has been in development for quite a long time. In short, you get smaller detector pixels, which leads to increased resolution, elimination of noise, spectral imaging, which is the iodine toggle on and off, and brightening that I showed before. And we get an increase of signal to noise ratio. There are other vendors also working on it. Currently it's Siemens, but GE is also working on a model as well to be released in the next few years with different materials. Currently we're the highest volume site for cardiac photon counting CT in the world. We got ours in January of 2023. And this had an immediate impact in the first month with indeterminate coronary readings decreasing from 18 to 11%. Now it's much less than 5% with this extremely high spatial and temporal resolution technology. Here are some examples which wouldn't be considered very significant now for us, but here's a calcium score of 908. We can perfectly see the calcium, no issues with blooming, and this is ultra high resolution at 0.2 millimeters. Here are multiple stents. So in this semi-sharp reconstruction with ultra high resolution, we can see the individual stent nodes, which is typically not seen in traditional CT. Here's an example where we see not only the stent nodes and the overlapping stents, but we also see the calcium outside of the stent nodes. So we know the exact locations where the stent was compressed. Here's an example of different kernels that we can use. And this is demonstrating that even with a very sharp kernel on the right, which traditionally could be non-diagnostic in our attempts to sharpen the calcium. However, in this case, because of the new technology, it's still diagnostic. You see a slight increase in image noise, but helps sharpen up the calcium and provides another tool in our toolbox to become more accurate. Here's an example of in-stent restenosis, which we can see very well now. So you can see this was a pre-op patient for a non-cardiac surgery with prior stent. You see at the red arrows, you can see soft plaque at the edges of the stent, and on the upper short axis image, we can see mild in-stent restenosis. So we can confidently rule out significant obstructive disease in this patient. Here's a comparison. On the right is an energy integrated detector, which is the traditional technology. And this is from a good scanner, what's considered cutting edge for energy integrated. But you see the significant difference in the image quality with individual delineation of nodes and soft plaque within the stent. So a very big jump in resolution. Here's another case with an example of an aspect of this, which is calcium removal. And it's called pure lumen on this technology. So you might say, what is the utility of this? I think the utility is a communication with our colleagues in interventional who are using luminogram, right, which just shows the lumen. And this can generate an image which is very similar and helps the communication and a seamless integration between the technologies. We published one of the seminal papers in the field just this year in JACC, showing the diagnostic performance of photon counting CT. Here was the study design. So there was a matched comparison retrospectively with photon counting CT patients versus energy integrated. About 4,000 patients in each arm. And what we showed is that the diagnostic performance for photon counting CT was better. That's on the left, from 93% to 97%. But what we know about CT for coronary is that traditionally the negative predictive value is very good and positive predictive value is not so good. And this is where the biggest jump was seen. So we see in the positive predictive value, energy integrated 63%, photon counting 83%. And what this translated to is a much better ability to refer patients into the cath lab who actually need stenting. And this is good for the patient and also good for the bottom line. So taking out the diagnostic caths and putting in only real interventions. Here's a slide of TAVR. So why am I showing this in the coronary portion of this talk? So CT pre-planning is the standard of care for TAVR. And nobody would ever go in blind. And the question is, why should coronary intervention not benefit from the same? The question I've had for a while, and this area is actually moving forward now. When we look at structural heart team, this always includes an imaging specialist, and we all practice this day to day, and it's in many publications. There are a few publications on the coronary heart team, and none of these that I've seen have included the advanced imaging specialist. Here's a trial which is being run right now, so it's a randomized trial, still in investigation, called P4, CT-guided PCI, and it's a randomized trial to CT-based pre-planning versus intraprocedural imaging-based PCI. Here are some examples of the concepts being demonstrated in the trial. So it seems very simplistic from the structural heart standpoint, but it's not really been done much in coronary artery disease before. So looking at the overall picture, where is the calcium in the overall coronary tree? Where is the orientation of the coronary ostia? You can choose your catheter rather than digging around with various catheters. From the CT, we know the various locations of the plaque. We can characterize not only where these are, but what type is it, how much calcium is there. Is there a necrotic core, which is a high-risk plaque? Is it fibrous, fatty? Where is the calcification and how dense it is? This is a picture showing an overall calcium burden of 34%, very high. Myocardial mass at risk is something being looked at. So how much do each of the branches contribute? And there can be quite a bit of variability in the subject. What are the best projections? So just like we do the fluoroscopic views for TAVR, what are the fluoroscopic views for the various vessels? A moving image of our entire coronary tree, which can be imaged side by side and co-registered with the live angiography. And FFRCT, which we're familiar with, where are the gradations and step downs that are significant. So here's an example of a certain patient with 2 step downs you see in the mid LAD and the mid to distal LAD. This is a virtual stent planner, which is being used as part of the trial. So it's telling you what is your FFR going to be predicting after the test, after the PCI with various stent lengths and stent locations. What is your morphology side by side with the FFR-CT? So here's the strategy potentially for this patient, PCI for LAD, you're choosing your catheter, your projections, you know your calcium burden, and here's the plan based on the stent pre-planning projections, 1 drug-eluting stent in the LAD. Here's the study, so we can see the same lesions, which look identical. Pre-PCI, FFR is 0.71, very similar to what we saw in our diagram on the right. That's our CT diagram. Here's our final result. Our FFR was 0.88, which is exactly what was predicted from the stent pre-planning simulation from the CT. And the important points from this is that we knew mixed plaque with non-circumferential calcium, no need for dedicated calcium preps techniques, right, like lithotripsy or cutting balloons. The combination of the CT anatomy and FFR-CT showed the extent to cover, which was the 40 millimeters area. There was perfect agreement between the FFR-CT and the invasive, both pre and post. So this really leads us to a confluence, not only in structural imaging, but also in coronary imaging, where there's an overlap, again, between the advanced CV cardiovascular imager and the interventional cardiologist in the field of CT-guided interventions. Here's a workflow which is currently being performed in the trial where we're kind of getting the angiography and CT side by side. Ultimately, if we're successful, a lot of this will be redundant, and I think we're going to get there. And then it's going to become much more streamlined where we know most of the data from the pre-procedural CT, and we just go in, target the exact lesions, avoid everything else, and create a much shorter and more efficient procedure. So this is going to be a true integration for intracoronary imaging and CT, and the collaboration increasing again between the imager and the interventionist. So in summary, for this whole talk, we need more imagers to do all of the imaging, and this is going to require support, recognition of what's actually being done in the field, and reimbursement as well. Short plug for St. Francis. I mentioned some of this. Here's a QR code. As Partho mentioned, we have about 6 total positions for advanced imaging fellows for all the modalities. Right now, we're recruiting for 2026. So if there are any fellows interested, feel free to apply. Thank you very much.
Thank you very much, Amar. That was I would just want to tell this that I've gone into many such presentations on advanced imaging and structural imaging. I wanted to just compliment your talk was very well balanced. So it started with the current problems, but at the same time, it ended up with a tremendous amount of hope and an assertion that I think the future is gonna be an eminent acceptance of imaging technology into the prime time applications in cardiology. Before opening the floor, I just want to create a debate with you. Correct me to the next 10 years journey. I want you to go just kind of extrapolate your current practice and what you're doing with technologies and move ahead and tell me 10 years from now, why would someone, if unless it's a medical emergency or an acute ACS, not do a photon count CT for a suspected coronary procedure, before a coronary procedure or testing, before even the patient ever goes into the cath lab?
I think there's no reason not to do it. I think we have to get to that point, and there are barriers, some of which I mentioned. That's
So,
having the CT scanner, having it in the right location, having it, which you'll probably get to this question, but I think integration is a huge issue. That's probably one of the biggest
yeah, I think
issues.
we have a lot of challenges, but let's say in the best world and the best centers, and if you have everything cleared out. Um, you want to know what am I getting into before you really go inside and try to do something, right? We are blinded otherwise. I mean, so there's always, I mean, remember 20 years back, we didn't have navigation tools and we used to go to remote locations, taking paper maps and trying to find out what paths to take. And now we practice differently. I mean, we use our navigation tools and we plan. So you could foresee, despite all the barriers and the evidence that we would need, that practically almost every coronary procedure could be planned. I mean, that's one. And hold on to that idea. But let's say on the other side, let's think about, and Jim Min talks about from clearly, every cancer, the smallest disease, we go for imaging and we look for it and we try to take care of it. In coronary artery disease, the largest killer in cardiology, and we wait for the plaques to go to an extreme occlusive state before we treat them. And now, with the emergence of the pharmacotherapy and where the coronary plaque volume reduction and stabilization is a major paradigm. So you also see imaging can play a role. So tell me, why should not someone have at the age of 50 or what number that be, just like a routine colonoscopy or a coronary CT? I'm just putting out there because would you want to know? And it's a big debate. I'm not, there's nothing like screening in cardiology. But imagine you could get to know your journey and plan it out of how you want to do and what pharmacotherapy or can you just position yourself? You think?
I think there's absolutely no reason not to do it. And I think there should be cardiac screening. And all of the things we measure, LDL and all these other metrics, are secondary metrics, right? There could be somebody with high LDL with no coronary disease, and there could be somebody else with the same LDL and factors with coronary disease. So we're measuring a secondary marker, which is causing something which we're not looking at directly. So I completely hope we go on that path. And I think a lot
Okay.
of cardiologists who I know do go on that path for themselves.
Yeah.
We're unfortunately not allowed to always do that for patients because it doesn't meet into guidelines. But
Yes.
many people I know have paid out of pocket. They just want to know, do I have CAD or not? Right? Rather than LDL up or down and what do I have? I'm not sure. What is my risk score? So I
Yes.
think we preempt all of that. And I think and hope that is the future.
Yes. So not to go to 10 years from now, where I think we are talking about. Let's talk about 2 or 3 or 4 years. Do you think all the CT scanners will be changed by photon count CT?
I think it is the future. I think it only has advantages and no disadvantages. The issue right now is cost, but of course that will decrease as the materials become cheaper and there are more competitors. So I think the within the photon counting, that's one aspect, but it's the higher resolution, both spatial and temporal. So I think that's the way we're going to head because, and we've noticed, which is in our paper, that the referrals for stent imaging have actually increased quite a bit for us once people knew we had this technology because now we can see inside of it. It's no longer a contraindication. Very high calcium, no longer a contraindication. So even patients with I'm sure you see these with tons of history of CAD and stents, and every time you go in and cath them when they have a chest pain, Now we're able to rule out a majority of those patients. They don't have anything different than what they had the last time, or potentially saying they should have a functional test rather than going in just to see if there's ischemia. So I think it is going to become the future, and it's gaining a lot of steam.
Yes. And then, there's a question that's coming up from Yasmin Hamrani, who's our structural director, imaging director. So with AI coming in, imagine you can also think about the imaging being done and the AI helping with the interpretation and potentially reducing the cognitive load I mean, I also see the photon count CT with the images it will reduce the cognitive burden for people who have not done specialized training in coronary CD to be able to still interpret the images, or maybe the AI interpreted images, to develop the plan of care. Almost to the point that one should wonder why even an interventional cardiologist should not take training in imaging. And I know of a lot of interventional cardiologists who actually know CT coronary angiograms and interpret them. So do you foresee maybe a hybrid pathway where there is no like an imager, but no pathway of cardiology, like be it structural valvular specialists or a coronary specialist, could do away without really having training in imaging?
Yeah, so I think all of my colleagues over the years who have asked me, who are interventionists, I told them to get CT training. It makes perfect sense for them. And it may be, I mean, I think it's an overlap zone. So for the AI part, which you're much more of an expert than me, I think even though we train these AIs on the traditional images, I think it'll be much easier with the new images, which are much better. Right? The better images you put in, the better it's going to be. And when you think about it, I think I always tell my fellows, I don't like coronary imaging. I like structural better, because structural, you're doing huge structures, right? Making like big measurements, which are 400 millimeters squared. Coronaries, you're looking at these small things. There are 30 branches, and it just takes a lot of time to read, especially when there are findings everywhere. I think that's the part where AI is going to really help us reduce the cognitive load. And volumes for coronary CTAs with the 2021 guidelines have exponentially increased. And I think everybody's struggling with that. I was joking around with some people that 5 years ago we would say everyone needs level 3 fellowship. Now we're saying take a weekend course and come start reading because we're so overloaded with studies. That's the point we've gotten to.
Yes, you're
Um,
correct. Yeah, please go
and
ahead.
and I think for the interventionist, I mean, their pathway doesn't have to be the same. They need to know certain things for their procedures, which is different than what has traditionally been reported with coronary CTA and CAD RADs, which I think is fairly useless for them. Um, so I think that is a big overlap zone, and I recommend to any interventionist to get training.
Yes, and I'm going to just quickly read some of the questions that are coming in.
Mhm.
People are very excited. The first one is, how is insurance coverage for CT for structural and CTA for pre-procedural planning? Do we routinely use CT-PCR planner, plaque analysis, etc.? This is coming from Yasmin.
Yeah, so for structural heart, it's a different code, but the reimbursement is similar to a coronary CTA. People say there's a lot more planning in structural, so it should be more, but I actually don't find it much different, because if you have to read 30 vessels, then I think that's a lot of reading as well. I think they should, I mean, they both did, there is a reimbursement increase now for outpatient, which was just approved. Um, and then what was the second question?
And so, do you routinely use CT-PCR planner, plaque analysis, and things like that?
Yeah, so that's a question. So the codes now for the more established code is for FFR CT. That's been around for a while. So we use it on selected cases, maybe 15%. Although in my personal practice, with the new scanner, my practice is shifting where I use it probably less overall. And I use it more for the cases where I know they're going to go for intervention, rather than the ones where I'm trying to decide, is it significant or not. And that's because we can see the lumen so much better than before. And the interventionists like the FFR CT for planning. And then with the plaque code, which is a separate code that's a relatively newer, there are rumors of it being reimbursed in various geographies, but not much certainty yet. And then the next question will come up is, we pay for these clear leads and heart flows. which the cost is pretty high. And can we just do that on our regular workstations with the vendors and bill for the same thing, which will be better at the end if we can get there. So I think that's an area which is still transitioning right now.
So this is a question from Ashok Chaudhary, one of our interventional cardiologists. How are your imagers participating in ICE imaging? No reimbursement, yet great value added.
Good question. So I alluded to it in the talk. So right now, an imager cannot be reimbursed, cannot get RVUs for ICE of any kind. That includes performing it or reading the study, and that's because of the way it's defined in the reimbursement codes. It has to be an operator, and the imager is not right now defined as an operator, which they probably should be. So for us, we're salaried. It's institution by institution. So we're just on a rotation for whoever's on interventional. So we go in and help out because we're on the interventional rotation that day. But it becomes a big issue for centers where they actually look at, what is your time? What are you doing at a certain time? And then you could spend a while in a case doing some ICE interpretation and then have no RVUs to show for it. So that it is a major issue right now, which is being discussed in many of the societies.
CT and cabbage graft target planning.
Yeah, so there is a study on that. I think Fast Track Cabbage. It was being close to being published. I don't know if it was, but I think the abstracts were very positive on the use of graft planning, and that's being extended to other studies, also looking at other aspects of the planning, like the veins and everything else. So I think that it will definitely be an area of future use.
Dr. Haig from Chief of Cardiology from Coupam and Barnabas asked question, CCTAs with high calcium scores. Is it possible to comment on whether the calcium is super or deep, or does that require photon count CT?
All right, let me look at it. So
The
well,
coronary CT angiograms with a high calcium scores, is
yeah,
it possible to comment on whether the calcium is superficial or deep, or
okay.
does it require a photon count CT?
I think it's hard without the ultra high resolution. I mean, we've looked at studies where we had done a traditional CT 2 years ago, 2 or 3 years ago, and now we did a photon counting CT. So you would expect the calcium to be at least equal, if not more now, but now it looks less. It looks much less. So we get a significant amount of blooming and misinterpretation on the level of calcium and also the location. So I think you need ultra high resolution for sure, and then the photon counting, the spectral part also helps.
Yes, we covered the cabbage planning, so I would just take Katie Wood's question on LVAD planning or other surgical planning using holograms. I think that's probably an affirmative, but I would let you answer.
Yeah, for CT planning, it's a good question. So I think on general CT planning for surgery, I think it should be done. I mean, we've had a few publications from Columbia on sizing the valve, surgical valve from CT, and there is quite a bit of discrepancy in what you get from CT and what you get from the trocar in the case where you size and the heart is deflated. So I think the very good structural surgeons who are involved in a lot of structural cases tend to use CTs a lot more for planning their open surgeries as well. Holographic is early, and it's right now the systems are kind of bulky. You need a big headset and a big system, but I think that will be an area of the future, especially for things like congenital cases where it's kind of hard to appreciate the anatomy in 3 dimensions. I think that's a place where holography will be very helpful.
Yeah, I think there are more recent glasses that are coming in which will allow you to have more interactive interfaces. I think
Yeah,
that's an area that is going to come up
yeah.
very quickly. Dr. Who's section chief of non-invasive cardiology and director of EchoLab, asks a question: what software do you use for your structural cases? Do you plaque quantification to look at vulnerable plaques? Do you do plaque quantification?
Yeah, so we use mostly 3Dimensio is our gold standard for structural heart planning. And for plaque quantification is a good question. So I polled a lot of referring cardiologists and I asked them, what would you do differently if I told you there were 2 millimeters cubed of plaque or 50 millimeters cubed? And it was non-obstructive. And most of them said they wouldn't do anything differently. If the patient wasn't on medical therapy, they would put them on the starting medical therapies. But I think that's an area which is being studied in trials right now. So there's the DECIDE trial with HeartFlow. There's TRANSFORM, which is starting with Clearly, where more of that's going to be delineated. For example, what do you do with these various tiers of plaque burden and plaque type? We don't know that yet. There was some headway on that with interventions with the PREVENT trial, where they showed with a certain load of plaque and a certain type, high risk plaque, there was less restenosis of stents in this certain group, even when the stenosis was non-obstructive. So I think we're getting there slowly.
Okay. So, Yasmin has a few more questions, but I wanted to ask a very important question to you. So, you made a very important point, advanced imaging cardiologist. What do you use for your work RVU target? Because I asked Dr. Bakari and others, because many times you do a lot of work and you don't get an equivalent amount of work RVUs. Yet, our administrative teams, when they apply our skills, uh, they're using the invasive cardiology work RVU targets most of the time, which, in my opinion, may not be right. How do you structure this? Because there's also an impact on the downstream revenue and the other aspects of cardiology, procedural integration that we contribute to. So, how do you scale productivity?
Yeah, so it's a very tough thing to do. I'm lucky to be at an institution where the system kind of understands that the imaging is needed to do a lot of other stuff. So, but for those struggling, I would recommend that that's really the way to pose it. It's very hard to make a high amount of RVUs with just imaging. And the more structural imaging you do, the fewer and fewer RVUs you're going to make,
Yes.
which is why many people don't want to do it. So even when I give presentations or make proposals, give yearly summaries, I have a different slide on imaging supported procedures and how much revenue did those generate, because I think that's really the bottom line of the downstream you were talking about. Even there, we're not capturing everything because there's other stuff in there that you could argue, but it's a much higher revenue and actually shows what we really do versus just the RVU
Yes.
determinations.
And I'm sure that we're going to let you go, Omar, but I think there are one or two more questions. I think we are already 4 minutes above our time. For structural TE imaging, do you use the same vendor machine is it the interventional echocardiographer who runs the machine for both ICE and TE during the case, or the reps?
So for TE, we run it ourselves. For ICE, it depends. If we get a rep, we're a Philips shop, so we will have the Philips rep there. But it's I think we'll eventually have to not have them there because that's going to increase and there won't be as
Yeah.
many people there. But it's fairly similar. If you're used to doing 3D MPR from a TE, it's going to be the same on ICE. There's not really a difference, and there's more workflows being published. We just recently got one accepted on how to use your MPR ICE workflow for, and because you were involved in some stuff. But yeah, for TTVR and TIR. So I think that's going to be an area which is going to be a workflow which you're just going to follow, which is going to be pretty easy to do.
Yeah. And then there is a question that's coming up. Could robots do the AI-equipped robots do the procedures for imaging procedures someday in the future? I think the answer is it's interesting that there is a, I'm just responding to it because I think there's a paper that is circulating right now. Maybe Omar, you were involved in reviewing. I mean, I should not put it out, but I think it's going to come out very soon. But there is a very lot of interest on at least TEE guidance using robotic TEE procedures and so I almost answered that question. So I think more evidence needs to be generated. And the final one I'm going to ask you because Dr. Maganti and myself, we scratch on our head because, back we were having people doing with level 3 training and level 3 labs because structural procedures, valve diseases really require a lot of intense TE imaging and abilities to be able to do those work. But but we don't have a ability to create that workforce anymore. How do we navigate that? And answer, please answer that. And the second one, I'm also seeing a technicians attrition because more and more technologists and sonographers are moving away to industry. So we are also seeing an equal amount of burnouts and attrition in technician. What do we do with these two big challenges? How do we run our labs?
Yeah, they're big problems. I think we see that in all the modalities, the expertise issue you're talking about. And that was the joke I made about taking a weekend course because it's just not possible. That was an exaggeration. But I mean, for our lab, we have a dedicated group of imagers who go into cases. But for the diagnostic cases, whoever's on T has to do it because we just don't have the ability to have certain people doing certain things at all times. And what the way we've done it is that 3D echo is the norm, right? That's bread and butter now. That's no longer some advanced thing. And we just have the interventional echo people just create a protocol, and that's what everybody follows. So you get a tricuspid case, the protocol's on the wall, that's what you follow. So we get enough information from that to determine eligibility and what can be, if the procedure can be done or not. So that's how we proceeded. And the same thing with CT. Now, my experienced imagers in other modalities, I'm just sending them for the course. They're doing some on-job training, and then they're ready to fly on their own because it is the workforce issue. Sonographers turnover is the new norm. So we've made affiliations with sonographer schools. Right, we get people coming in, they'll join for a while, but eventually people are going to go. So you just need an ever rotating group of sonographers because I just don't think you can keep them.
Yeah. I'm hoping I have not missed any questions. Just to close, I would just want to thank Amar for your valuable time. I really enjoyed, and I think our people all enjoyed, and I think we have to bring you back because this journey is just getting started. So maybe an annual refresher would be very much appreciated. So we look forward to having you perhaps in person next time, and look forward to more collaborations as well.
Absolutely. Thank
Thank
you
you
for
very
having
much.
me.
Good night, everyone.
Good night.